This conference will now be recorded.
Hi, everyone. Welcome to the AnCan High Risk, Recurrent, and Advanced Prostate Cancer video chat for Monday, January 20, 2025. I'm Len Sierra. I'll be moderating today with a little help from my fellow moderators and all of the attendees here. We want to acknowledge and thank our sponsors, and they are Bayer, J&J, Myriad Genetics, Novartis, Telix, and Blue Earth Diagnostics. And we'll start with an announcement from our founder, Rick Davis.
Yeah, good evening, everybody. Just to bring your attention to a couple of items that were in the reminder, and most of the people here are well aware, but there are people listening to the recording, and that's the reason that I'm doing this again, not for the people in the room. But we are trying to tie up our end of year annual fundraiser. As of last week, we were somewhere around 7 or 8% of this group contributing, which is kind of disappointing. Last year, and the people in this group don't know this, we had 33,000 views on YouTube, of which over 16,000 were for prostate cancer. And the majority of that was for this high-risk group because we didn't start low intermediate until August or September. So if you listen and you appreciate, then please consider making a donation. The price of a Starbucks latte once a week over 52 weeks makes a nice donation, and we would appreciate seeing your gratitude. For those of you who have donated, and that includes most of the people in this room, if not all, then thank you so much, and it's really appreciated. Second thing is that Dr. John is making tremendous headway with the survey analysis. We have some data professionals, I would go so far as to say, lined up to assist with the analysis, including a professor at Houston Methodist who was formerly at Case Western, and some of our own people who are very, very good with data. And so we're excited to look and see what the survey reveals this year about prostate and also about all our other groups, and what conclusions we can draw. If you haven't filled out the survey, especially the people who listen to the recording, please do so. The survey address will be in the chat window. And I am through, and it's over to you, Mr.
Okay, thank you, Rick. And before I forget, I would love to hear Jimmy Greenfield's imitation of you, Rick, if we ever have time to do that. That would be good. Okay, but for now, we will start with Craig Christensen, who is new. And Craig, I know you're familiar with our questions, so let's go through them. First, tell us how old you are.
76.
76. And where do you live?
Denver, Colorado, or Boulder, actually, and sometime in San Diego.
Okay. Where are you today?
San Diego, avoiding the winter storm.
Smart move. And, how did you hear about AnCan? Or I guess I'm not sure that matters since Rick already knows.
Actually, through Michael Wynn and our local Boulder County prostate support group.
Thank you, terrific. Michael. Okay, so Craig, when were you first diagnosed, and what was your Gleason score and PSA at that time?
November 2019, PSA, I believe, was 10.1. Gleason was 7, 4 plus 3.
I'm sorry, the PSA was 10.9?
10.1.
10.1. Okay. Okay, and so where were you seen? Who?
UC Health, University of Colorado Health Anschutz in Denver.
Okay. All right. And I believe they performed a prostatectomy.
Correct. Exactly 5 years ago today.
Oh, okay. And you have not had any treatment ever since, is that right?
That is correct.
Okay. But you have had a slight increase in your PSA, which is what now?
0.08.
0.08. And what was it? Oh, you mentioned a 13-month PSA doubling time. So 13 months ago, it was only 0.04.
Thereabouts, right. It was for 2.5, 3 years it was undetectable, and over the last year and a half or two, it's been slowly rising.
Okay. And you've had, have you had any scans either before treatment or since? Right.
MRI and both scanned before, none since.
Okay. So I'm not sure how we want to approach this, but I understand that in your email, there seemed to be some confusion, at least on our part, as to how it is that you had a Decipher test, and somehow they, in the report, they said something about neuroendocrine-like disease.
Correct. So the Decipher score was 8.1, high risk or aggressive in the standard Decipher 2-page report. I also got a copy of what's called the Decipher Grid report, which is 7 pages of lots of detail about the genetic mutations. And that's in there, of the 160,000 individuals that have had Decipher tests, they categorize in 4 categories, the last of which is the small category, 5 to 8%, that they call neuroendocrine-like, based on the genetic results, not pathology.
Did they do any somatic testing on genetic testing on the cores that they removed when they were first diagnosed, or on the prostate after they removed it?
So negative in terms of the biopsy cores, but I requested the Decipher test last March or so, once my PSA ultrasensitive had gone up, and that was done on the prostate samples after prostatectomy.
And did you get results?
Yeah,
Yes.
I mean that's what we're talking about, Len.
That's the results we're talking about.
That's what we're talking about. That's the Decipher 8.1 and the grid. That's what Decipher. You may not be familiar with the Decipher test. We don't see it too much here, but the Decipher test takes a sample from the prostate tissue and estimates how likely you are to see metastasis, and grades it on a scale. And then there is a second test, which frankly I'm not that familiar with, which is this grid, Decipher grid, which is what said when they analyzed the tissue, there were mutations that might indicate neuroendocrine-like, but they don't as far as I know, I don't. Do they identify the names of those mutations, or is it just sort of a vague remark?
I have a lot of, so they test 22 genes, I believe, and there is a lot of information in the grid report about mutations, specific. There's the TP53, the
Right.
P10, all of those, and a number of other mutations are listed, the scores.
And they were negative? Or
Did you show? Do you show TP53 and P10 and RB1?
So the P10 says intact, and so I don't know what the word intact means.
sounds like it's normal.
It says
Wild type.
P10 loss intact.
P10
And
loss?
loss, yeah.
Intact. That's a weird way of putting it.
Yeah.
And what about
I
the
would,
TP53?
TP53, the tumor score is 0.18, and I'm in the population rank 8%, and there's no comment under status.
Rick, don't you think you should have a more traditional somatic genetic
well,
testing from,
well,
FMI or?
I don't know. I'm not sure because it doesn't really warrant it. And we're basing it on trying to interpret a report that we don't know. What I would be doing is calling Decipher and asking for some help in interpretation of this report and asking them, does this mean I have? Does this mean I don't have? Does this mean you suspect I have? Does this mean you suspect I don't have? I thought, I was going to come to you right away because I knew you would know more about this than any of us. Now you put your hand up. So go ahead, Eric, please. And unmute.
Sure. I don't know the specifics on the whole grid and the genomic part, but I do have a good contact for you at Verasite to maybe help you guide you.
Terrific.
Well, that would be great.
Do you want me to send it to the group or just to Craig?
Send it to Craig, and then we know you've got it. So send it to Craig. Have you ever run across this Decipher grid report? Did you get that for your stuff?
No, I don't know if it's new or if it's only done on prostatectomies. So obviously I haven't had one.
Yeah, it might only. I don't know.
It's referred
Dr.
to.
John has volunteered to take a look at Greg's grid report. Is that okay with you, Craig?
Absolutely. That's the kind of thing I'm looking for, is to understand a little bit more what all this data means. It is labeled as research use only, but I had seen online individuals that requested it, so I did that and received it from Verasite. But I am having trouble finding help to interpret it. So that would be what Eric's suggesting would be great, and Dr. John's interest, that'd be terrific.
Well, Dr. John's a researcher, of course. You know that, don't you, Craig?
I don't know his background, but yeah.
Don't expect us to know a lot about this Decipher report because we are all very mystified by it. And we still have to learn about what Decipher is up to now, releasing these so-called grid report and having a neuroendocrine category. This is all new for us. So I'll try to figure it out as best I can.
Thank you.
But I'd be more comfortable, as Len says, with a traditional somatic test. Let's see what we can find out.
What would be the more traditional type test?
Well, let me just address that, and we'll go to you, Dr. Jeff, in a second. The traditional test would take your prostate tissue or any tumor tissue, and it would analyze it for a large panel, 300 to 500 mutations, as to what they find in that tumor. And the people who do tests like that are companies like Tempus, FMI, the one that starts with a C that I always forget, Guardant, who we're not big fans of, Myriad. There's 4 or 5 different people that offer that test. Now, if I would say, and this will be up to Dr. John, and we can come back next week and talk about it, that if there's suspicion of some of these mutations, then that might dictate what you do next. But the issue is that if you have TP53, you had P10 loss, which I suspect you don't because it says the P10 loss is intact. There's no, which to me says no P10 loss. Then all they're saying is you are more likely at risk for your cancer to change into neuroendocrine. It's not saying they've seen neuroendocrine or there is neuroendocrine there. There are several mutations that are called tumor suppressor growth mutations. Those include P53, E10, RB1, NBN, and a few others. And what we know is that when you express those mutations, your progression is impaired. So General Joel, for example, has a couple of those mutations, and Dr. John has one of those mutations. It doesn't mean that they have neuroendocrine disease. It means that there's a greater risk for their cancer to become neuroendocrine-like, express small cell over time in response to a lot of treatment. But you're not there. Now, how does that affect where you go from here? What I would suggest is you bring Dr. Rana Mackay on board at UCSD because she's super smart. You share this information with her, and over time, as you watch your PSA, which is, what did you say it is currently, 0.08, she'll know when the right time is to ask for a PSMA test. And she'll also, and that is what I would be doing right now. I would be getting a smart GU med on board early as a result of what the Decipher test we think might have said, and let her pursue it. I'm not sure, and she'll know when it's the right time to get a somatic testing for you.
Right.
Dr. Jeff, you're up.
So, Rick, your assessment is correct. P10 is a tumor suppressor gene. Intact means it's present, and that's a good thing. So any result that you see that intact, it means it's a positive on your side. It's there. It's a tumor suppressor, and it's intact. So that's good.
Okay, thank you for that.
That's great. So Rick mentioned RB1. I see something here called lowercase p RB loss, but that also says intact. Is PRB likely to be the same as RB1? Or we don't know.
I think maybe the P just means pathology, so that was determined from the removal of the prostate.
I don't know. It's listed, Len, with all the other things which are based on the somatic testing, as I understand it, with Decipher. But I can try to. I'll ask Dr. Mackay or McKay that question as well. And I guess just one other question, if I could put to the group: if and when is the time to get salvage radiation? I'm interested perhaps in MRI guided radiation therapy. I know that Dr. Mark Merlot on the other group is very familiar with that. Any experience here or recommendation about where to get MRI guided radiation therapy.
MRI guided implies that they know where the lesion is. Like, how are you
Uh,
going? What is
True.
the MRI being guided toward?
Good point. I mean, I've read that they use reduced margins, for example, when doing it as initial treatment of the prostate. I don't know if one's doing pelvic girdle, I think is Rick's term, treatment, whether it's used to have margins to avoid the rectum. That's a good question, Len. I don't know. Yeah, what
Rick,
you're saying is if it doesn't, it might be useful if one sees something on PSMA, lymph nodes, for example.
Rick, you had your hand up.
Well, Jeremy, why don't you explain how they went about doing your radiation when you're they just finished? You just finished. You're still is still doing. How did they guide that since they weren't sure where the lesions might be?
What, hi, can you hear me all right?
Yes.
Well, Rick, you and I went back and forth on this. Ultimately, and again, I have AnCan to thank for this, and you, Rick, we went to the pathology report. And again, I would encourage you to get the pathology report. Based on the pathology report, I had all negative margins except for one area at the bladder neck, left side of the bladder neck. They got negative margins after they resected, 3 or 4 more times, but that was where the problem area was. And they basically, it's City of Hope, doctors Percy Lee, the rad onc, and the medical oncologist, Dr. Sandy Liu, both felt that the area most likely that was lighting was causing the microscopic disease or slow rise in the PSA would be at the bladder neck. And so they decided to target that area, as well as, and I fought for this a little bit, wider margins around the prostate bed. Although they did not do the whole pelvic bed, Rick, and they didn't do the lymph nodes, but they did do a larger field, and they put me on ADT. But all my PET scans are negative, my MRI scans are negative, and it did leave the question: what do you do? What's lighting up in there? But what I learned, at least from them, is that you don't wait. You don't wait till it lights up.
Right. Pay attention, Larry Schuler, because we're going to be talking about this when we come to you. You don't wait. I think that that you've got to watch that PSA carefully. You're going to be monitored, hopefully. It may be hard to get an appointment with Dr. MUTYH right now because you may not be well, and she may say, "Oh, I won't see somebody until they get to a certain point."
Mm-hmm.
On the other hand, since you have that grid report, it may be enough for her to say, "Okay, come on in, and we'll work together on this." And we kind of know her, and we know people who know her well. She's really nice. And we may be able to lean on her and say, will she hold your hand until that point where we think you need a PSMA scan? Now, that point is not going to be until probably around 0.15 or higher, maybe even 2 to get a result. I think what you can take away from today is, number one, and this is what we were concerned about, you might have neuroendocrine disease. Unlikely that you have neuroendocrine disease. Right. You may have tumors. There may be a suspicion of mutations that could lead to small cell neuroendocrine-like disease, but we're way a long ways away from that at this point in time. no more than probably half the men in this room would have gotten that grid report if Decipher had done a test on them.
Mm-hmm.
So I want to put your mind at rest on that. At the same time, exactly what Jeremy said, and I think what the other moderators would say, is don't hang around with this stuff and be ready to move when the time is right. How do you know when the time is right? Well, number one, if you've already got a good GU med-onc in your back, in your hip pocket, like Dr. Anna, she'd be great. If you can't get her yet, you keep coming back to us and saying, well, this is my PSA, this is my PSA, and the guys will tell you, well, I did it at this level and I did it at that level. If you have, I don't know who did your original surgery. If they're smart and knowledgeable, you can be talking to your original urologist as well. But those are sort of the only sources that I can come up with now. My first choice would be Dr. Anna.
Mm-hmm. Okay, me as well. Anyone else in the San Diego UC system in terms of a urologist, or would you get good on a team?
Well, I mean, yeah, there are a couple of really good urologists, and there are a couple of very good radiation oncologists at UCSD, like Chris King. But you might be able to get in. That might be another way to go. I think it's Chris King who's the radiologist, or is he the urologist there? I'm thinking he's the radiologist, but I might be wrong on that. I could be wrong on that. But yes, there are some people that we know at UCSD. That's where we would shepherd you to UCSD rather than to Scripps.
Mm-hmm.
Though we recently had a guy on the call who was at Scripps, but I'm not sure how well he's been treated.
And any recommendations in Denver?
Denver's really tough.
Yeah.
There are a couple of people in there at Denver, but nobody. I mean, yeah, there's a GU med-onc in Denver. Elizabeth, forget her last name. Mike will remember. He'll stick it in the chat. But
I know it's Kessler.
Kessler, yeah. But she's, she hasn't impressed us. Doesn't mean she's bad. I'm only talking from the standpoint of AnCan. She hasn't impressed us, and most of the time with our people who are in the greater Denver area, we've sent them off. We have hands up, Len.
Yeah, I think Jeff Markey was first. Go ahead, Jeff.
Yeah, just a couple things. After prostatectomy, if your PSA hits 0.2, that's usually when they do salvage radiation. And number two, salvage radiation is done with IMRT, and they do have like Meridian SBRT, which has an MRI built in. I am not sure do they have an MRI IMRT? Anybody know?
I would say let's not go there and get into that discussion right now, because we don't need to. At the time that we need to discuss radiation alternatives, and there are many, especially with you, if you're in San Diego, we can talk about them. But I'm just keeping an eye on the clock. We still have to talk to Larry, and I don't want to go down a rabbit hole and create a discussion around salvage radiation right now.
All right, Jeremy, go ahead.
Yeah, Craig, I was just going to say there were a number of patients from San Diego when I was up at City of Hope at Irvine. They took the train daily for the treatment. It was very easy. Very easy, very convenient. So I just wanted to leave that with you.
Yeah. I mean, Jeremy's been happy with his treatment there at UC Irvine, and other people. We've now got
City of Hope at Irvine.
Oh, sorry, City of Hope. Excuse me. City of Hope, not UC Irvine. We've just had somebody else up to go, so that may be another. But for me, as good as they are, I'd still go to UCSD before City of Irvine if it were me. Before City of Hope in Irvine, that would be my preference. If you're in San Diego.
Mm-hmm. I think the thing that was interesting about Irvine or City of Hope is the MRI guided option.
They have it everywhere. Okay, I suspect you're going to find that everywhere, unless you're or getting to be everywhere. But that's that MRI guided option that you're talking about is what Kishan does.
Mm-hmm.
Jeremy, didn't they do that? Didn't they give you your radiation in a tube as well?
Yes, MRI guided.
Yeah, so they have it. They do have it at City of Hope, and I don't know or not if they have it at UCSD. Would I travel for it? I don't know.
Okay.
We move on, Len, because I'm just.
Rick, why don't you do Larry? You were going to summarize Larry.
Larry, it's great because this conversation has so many. It's so similar in a way to your history. I mean, there are differences, but there are also a lot of similarities. So let me just pull up the notes that I made. Let me save this.
It's a very long-winded summary of my situation to Rick. Much too long to present here, so he's going to summarize for me.
Right. So I'm doing this on the basis of notes that I took the first time and notes that Larry just provided to me. So Larry lives in Alaska. He was treated largely, Fred Hutch, by a local doc. He is 74, I think you said. I forgot to note that down. You did tell me, am I right? 74?
Yep.
74. And he was diagnosed in 2023. PSA 4+3, multiple lesions, regularish size prostate, 33 cc's. But the big issue was he was T3B with seminal vesicle invasion and perineural invasion, but the seminal vesicle invasion is important, and that was confirmed on the radical prostatectomy. There was no metastasis seen from the scans, and he was told that whether he did surgery or radiation with T3B, he had an 85% likelihood of metastasis. What was your PSA at the time that you were diagnosed? Oh, yeah.
7. After the prostatectomy, they upgraded to 9.
Okay. Your PSA. What was your PSA?
Day before surgery at 13.3. 5 weeks after surgery, 1.33.
Okay, so it was 13.3 at the time, and I had you were 4+5, but then you didn't mention it in that write-up. So they upgraded you to 4+5 after the radical prostatectomy.
Yes. Took 2 lymph nodes and they were clear.
Right. So this was in October of 23. And the PSA was climbing all the time, but Larry, for various reasons, was reluctant to go on either hormone therapy or to have radiation. Now, in April of 24, he had some estradiol, and he started on estradiol E2. He switched to Orgovyx. He went back to estradiol and the Orgovyx. I don't know who was guiding him on all of this. He didn't tell me, but this is what actually he did. And his PSA dropped to 0.048 from the one level that he mentioned. And then he stopped the Orgovyx and maintained on the estradiol, and his PSA is maintained about 0.02. So here we are today, about 15 months, 16 months after the radical prostatectomy. The PSA is around 0.02. He's done no radiation therapy to date. He does have some gynecomastia and some mastiodina, which is pain in the breasts, in the chest, from the breasts. And he's looking as to where should he go next. The other thing I wanted to mention is that he has had a penile implant and he was considering getting an AUS. And I don't know if you did that in December or not.
Yes, December 17 got both.
Okay.
Later this I'll have them activated. Hopefully they'll work.
Okay, so you're still waiting, and we have people with that experience, with the AUS experience, certainly in this group. So, did I miss anything?
The estradiol has been keeping me down as low as 0.014, and I'm trying to think. You did miss a couple of small points, but now I can't remember what they were.
Okay. So where is your PSA right now as we speak?
I missed one of my estradiol doses, and one because of the AUS surgery. So it rose to 0.019. But for the past 3 months, it's been 0.016 or 0.014 or below 0.014 consistently.
Okay. So I would say to the group, your T3B, you had seminal vesicle invasion. You're managing your situation successfully right now with estradiol alone. How would anybody here view that situation, and what would they do, and what would be their attitude to doing salvage radiation?
Question. I'm aware that ADT is not curative. Radiation might be.
No. There's no such thing as curative in our view.
Right, that's what I said. ADT is not curative.
Neither is radiation.
Yeah. Well, my radiation oncologist says it is, but I looked it up, and
we would argue with him vehemently. What he can give you is a continuing and durable remission.
That's the words.
Okay? He can't give you a cure. Cure means you're done, it'll never come back. It won't recur. That's what a cure is. Can he give you a continuing durable remission that will go on but might come back at any time in the future?
What he told me verbally was use the word cure.
He shouldn't have done, in our view.
In the
okay? We don't want to set expectations for anybody that attends our group, that if you're a T3B, in fact, if you've got a 4 in your number, that we can cure you. We don't know how to do it. We don't have the science.
Right.
Talk to Dr. Jack. His disease goes back up to 20 years.
Pardon me. What I read, though, was I have a high percentage of no recurrence within 6 years. To me,
that's not cure.
You got to watch,
That's not cure, Larry.
No, I know that.
Right? But we cannot cure you. We cannot cure you.
I'm well aware.
Maybe a semantic, but we cannot cure you. We cannot cure you with ADT. We cannot cure you with Pluvicto. We cannot cure you with second-line anti-androgens. We cannot cure you with radiation. We cannot cure you right now with your level of disease. We couldn't cure you when you were diagnosed with T3B.
Right, you're preaching to the choir.
All right. I want to take a question or a comment from Jimmy Greenfield. Go ahead, Jimmy.
Thank you. It's very interesting, Larry. My past is very similar to yours in a way. I took all the treatment where you didn't take. I took radiation and ADT, even though I had an undetectable PSA after prostatectomy, because my pathology report showed seminal vesicle invasion, one positive lymph node, and it was a clinical trial, which was the estimation was that since it was so bound to recur, that maybe it would be more effective if I hit it directly right away. Studies have shown since then that doesn't make any difference. You can let it rise to 0.2 if it comes to that, but I'll never know if that made a difference. I do know that you're right, that even though there's some very strong feeling about cure not being possible, there are a lot of doctors who say there is. There's a lot of doctors who will tell you that cure is possible. Reason, of course, that cure is, we don't consider cure a word that we use because it does come back sometimes after many years. And longer you can go without it coming back, the better chance you have that it won't, or that most people will die of something else first, which is what we're all going for. I'm going for. What I want to ask you about is how do you like the implant and the AUS? I have an AUS, but not an implant.
Oh, I haven't used it yet.
You haven't used the AUS yet?
It's in. We have not pumped it up. It'll happen this coming Thursday.
Wait a minute, I'm talking about the AUS, not the implant. We have both?
The AUS is the new one. The implant is the one that got fixed.
Remember, Jimmy, this is John. Remember, Jimmy, after we got our AUS, we had to wait a month before he would so-called activate.
I understand, but I thought that he meant by implant, I thought he meant an erectile implant. We're talking about an AUS only having been done.
Oh, I see. Sorry.
He has both for me. Both. He got the penile implant in 2017, but it was damaged in the medical prostatectomy. So in December, when they did the AUS, they also repaired the penile implant. Jimmy's question is, how do you like the implant from before?
Oh, great.
Okay. The AUS, well, it's been the best and worst of worlds to me. It worked beautifully. It still works beautifully. I've had a lot of problems with fevers and infections of mysterious origin that are probably related to it, and I'm going to have to get it probably replaced. But I would say that Dr. John can speak to it. I find that compared to the relentless incontinence that I had, it's a beautiful thing. If the penile implant can do the same thing for my erections, that would be nice. I told myself I would not get a penile implant until I had a certain amount of time remission, and that time is approaching. So we'll see. But I always ask anybody who got an implant if they like it. And everybody I've heard of and everybody I talked to that had one says that they like it very much. So that's always nice to hear.
There is a website you can go to where a lot of guys have implants, franktalk.org. It's really full of information. I post there as lost.
Lost what?
Lost sheep.
Sheep?
LOSTSHEEP.
It's very easy to remember. Thanks, Larry.
Yeah. It's got 3 stories behind it.
Lost sheep. Okay, I'll take a look. Glad you're doing well.
Talking about infections, though, after my surgery, I have extensive lab testing done because I'm a blind clinical trial of one patient, and my white blood cell count went up a bit, no fevers, no swelling, no redness. My eosinophils went up fold, and that kind of made me curious. So the eosinophils is a kind of white blood cell. It's supposed to go up after a trauma, but didn't know how far or how quickly they should come down. So I am keeping track of all my lab work very closely.
Well, I have periodic pain and swelling in my testicles and my penis that is either acute or just sort of not acute, but is always there. So something's going on. I'll find out what it is. Thanks very much.
Yeah. Don't wait.
No, I have an appointment next week.
Okay. Larry, okay with you if we move on? We've got
Jerry Grimes has his hand up. And
sorry, go ahead, Jerry.
Just a quick question, Larry. Apart from the gyno problems from the estradiol, how are you feeling with that?
I'm fine with it as long as they're symmetrical, shapely, and small enough to pass the pencil test, and they're not going to bother me.
I mean, fatigue, mental energy, health.
I had cognitive decline with the Orgovex that went away when I quit that and then relied on estradiol alone. Extreme fatigue lessened. I'm still a little more tired than I was before this, before the ADT. So yeah, the side effects profile of the estradiol far superior to the Orgovex. And what I was really concerned about was diabetes. I'm type 2 diabetic. Insulin resistance is a problem with Lupron, and I imagine it's a problem with Orgovex as well. Osteoporosis is a concern. I was down 7% from your normal 75-year-old man when they did a DEXA scan. So taking exercise, weight-bearing exercise, and trying to all I can to build up my bones. So yeah, I picked my ADT very carefully.
Very good.
what I had hoped that we would pick up on was the need for radiation, some sort of follow-up radiation when you had significant recurrence of PSA, which Larry did, which at one point it was 4.67, but his choice was to just go with the estradiol and then mix it with the Orgovex and to avoid the radiation. We know that the best outcomes combine radiation and ADT, meaning that whilst there's no cure, the longest time to recurrence seems to take place if we combine radiation and ADT relatively quickly. Does anybody have any comment on that before we get into the rest of the group and the questions?
Go ahead, Larry.
I know one guy who's been on estradiol for 20 years without progression, another guy for 6, another guy for 4. Now, these are anecdotal stories. Usually, you get castrate resistance developing in the prostate cancer within a year or two. But there is evidence that if you have extreme low testosterone levels, the time to resistance developing is extended. Klotz did a study. They went from 50 nanograms to 20 nanograms, and the time to resistance was 1.9 times in the lower testosterone group. So I have hopes. Also, I reject radiation. I haven't completely rejected it. It's still on the table. But side effects of radiation, some of them can be, pretty devastating to your quality of life. So I'm watching very carefully what all my labs are telling me. and I will opt for that if I feel it's necessary.
Okay, guys, we've only got an hour left, and we have about 9 or 10 men who'd like some time, so I'm going to move on. We'll go to Alan Moskowitz.
Hi. So I will try to go quickly. I'll be careful with the time. Several weeks, or maybe it was in December, I mentioned that my PSA has started to creep up. I've been on a drug holiday for 3 years with sensitive prostate cancer, and so it's gone up. And I'm happy to say that the PSA has increased, but less than previous. So the doubling time has dropped. It was 3 months for 2 3-month periods in a row. This last one, if you just look at the last 2 points, it would be 8 months, but they're small numbers, so I don't attribute a lot to it. It jumped from 0.68 to 0.88. That's one data point. The second thing is I did have a PSMA scan in December. Rick pushed me last time to get it done as soon as I could, and I had that done at Sloan, where my doctor is. And they gave me the gallium agent, which was a Lusix. I would have preferred the Polarify. I mean, I heard the discussion a week or two ago about they're more or less the same. I did read that the Polarify might give you a little better resolution.
What were the results of the PSMA, Alan?
PSA, the result was very simple. They didn't see nothing. They saw one mildly avid lung nodule that I had previously, 0.3 centimeters or something. They found cancer nowhere else, which didn't surprise me. My oncologist was thrilled. He said, if you just have lung nodules, that would be great. But they only found that one. And, again, the PSA at the time taken was probably a bit less than the 0.88 or so. So that's really good. And the last comment is I used this guy, Dr. Chen at Sloan, and I had found out through this group that they have Chuck Ryan there now in New Jersey, very convenient to me. And so I told my doctor I wanted to switch because he's closer. And he said, great idea. He knows him very well. He was his professor when Dr. Chen was in school. And he has lunch with him once a week or so. And he said, that would be great. He said, we'll just sort of phase it in. He'll apprise him of my situation. And I have an appointment with him in person in July. And I will be continue to get my ultra-sensitive PSA test along with testosterone 3 months hence from the last readings. And so I've been doing it every 3 months since I had my prostatectomy in 2013. So overall, my doctor's happy. I'm extremely happy, and just hoping the doubling time continues to lengthen and be in good shape. I was hoping I really want one more year of a drug holiday, and I'm counting on this year. But if I have to go back on the drugs, I'm hoping by then that the approval will come through from the FDA for the use of darolutamide in castrate-sensitive prostate cancer. That's all pending as
it has come through. Alan, it has come through.
Is that right?
Metastatic. Darolutamide approval has come through. It's now approved.
For castrate-sensitive?
No, for hormone-sensitive metastatic, it has come through. Let's ask another question to the
without docetaxel.
Yes.
Right.
Let's ask the group another question. Would the group, maybe we'll have a hands up. Everybody know where the hands up function is? Okay, get ready. how many people in this group would continue in having heard Alan would test at a less frequent interval than 3 months? Okay. Okay. Anyone else? We've got, so far we're up to 5. I like this participation. So we've got 5 people in this group who would test more frequently than once every 3 months, Alan, at the juncture that you're at.
I want to know the rationale for that.
Okay, well, would somebody who put their hand up like to express the rationale? Go ahead, Larry.
I'm testing weekly because I am a clinical trial of 1 and I'm self-administering it. My oncologist doesn't prescribe it, but he said he wouldn't fire me if I got another source. So I found a GP willing to prescribe as long as I'm being followed. But I am keeping really close track on all my labs.
Okay. Anyone else want to express why they would test more rapidly? Len, you have your hand up.
Yeah, Alan, I would kind of reverse that question and say, why not do it every 6 weeks instead of every 3 months? Cut that time in half. It's covered by your insurance. It's just information. Why not?
So the question becomes, sure, I could do that. All right. And so I look at it and say, all right, I mean, I've never, and maybe I have to look at it again, but the thinking is, if it was jumping up faster at this low level, then I would do it. But I'm trying to understand, what would I gain? I mean, I'm a scientist, so I love data, okay? And I've been comfortable with every 3 months because I've never seen changes that warrant an action, warranted a decision by me, and sooner than 3 months. Even when I hit the close to the 0.1 or so, or 0.2, that triggered my radiation therapy, it was still every 3 months. And, the PSA wasn't going up that quick where I had to react sooner than a month or sooner than 6 weeks. So that would be one thing. Plus, I'm not the type to get nuts over if I see data that doesn't follow the line, right? You could get spurious data. So too much data may not be a good thing, but I'm not convinced just to have more data. I need a reason. Someone's got to tell me, yeah, because something really bad could happen within a 6-week period that you'll want to take action on. That would be really what's on my mind. I respect your opinion, Len, because I don't see any downside, really. I mean, I can live with crazy data, but I don't feel the PSA is going up so quick in a time point where I'm going to start taking drugs.
Go ahead, Jim Marshall.
What do you think?
Alan, you say you don't feel it. Well, the catch is you are assuming that nothing's going to go crazy. I was a scientist too, and I was a computer guy, and I want to know the good news quite often, just in case the bad news comes, to detect it as then early as possible. So that's the way I look at keeping a system up, nonstop for 5 years.
Right. Yes, I understand that. I guess if I saw my doubling time staying at 3 months, I probably would do that, maybe even every month. right now, again, small numbers, with that caution, doubling time has gone the other way to 8 months. And I'm expecting it to get closer to what my doubling time was before this round of drugs. So look, I don't want to take up time, but I will give it thought because I never really thought to do it sooner.
Dr. John, go ahead.
I was curious, Alan, what your T level is now.
What my testosterone is? Yeah, I'm not recovered. I'm about a little under 200. I think 180 or so.
And how long have you been off? How long has your treatment holiday been going on?
It's a little over 2 years. I ended at the end of 22.
Okay.
Yeah.
There's a small handful of us that have a little group email going on about that topic right now, who have symptoms of hypogonadism and are wondering if they should dare try testosterone or not. You have symptoms of having low testosterone? You're 200, so maybe you don't.
Yeah, I mean, my doctor said to me a while back, because it's my testosterone, even when I was normal, was only about 350 or 380
Yeah.
a number of years. So, down it's low. And he said, to some extent, it's probably help keeping the prostate cancer at bay. Yeah, I have hypogonadism. I lost muscle mass during that drug period, which I'm slowly building back up, hopefully. But I do the best I can.
All right, guys, we're really going to have to move on. Let's go to Mark Valence, and then after him, Dr. Jeff.
I don't need time, Glenn.
Oh, okay. Mark Valence. Valence.
Just Valence. There you go. Just like Richie. Just a little bit of an update. I'm 10 days into my third cycle of chemo. And it's the same every time: shortness of breath, fatigue, and low blood pressure. I'm dealing with. Only change is after dealing with constipation for a really long time, now I've got diarrhea. Don't quite understand all that, but the bigger news is I finally got my FDG scan, and they say stable disease. Previously seen PSMA positive lesions do not show FDG uptake. And there's some sclerotic bone lesions are present. But anyways, Dr. Agarwal took a look at it. He said basically it looks like good news. He said it's not going away, but it's not getting any worse. And then Rick, you'll be happy to hear this. He wants to compare the FDG to the PSMA scan, and we went through this whole thing about Rick thought they had to be real close together, and Dr. Agarwal said, well, they don't have to be real close together. But what he did say is they should be not too far apart. And so my last PSMA was quite a ways back, and he compared that to the FDG, and he's things are concordant. He doesn't see anything that might indicate neuroendocrine. And I get another PSMA in a week, so he'll look at it again. But he's hopeful that it's doing all right, and that there's not any neuroendocrine, which is what the original biopsy showed. But and then I got the next gen sequencing came back, and I don't understand all this, but they say MSI high is not detected. They say the blood tumor mutational burden is not much of a problem. And
Mark, why don't you just tell us what is reported as not normal or troublesome?
what's that?
Anything?
What variants did they identify? Did they identify any mutations?
The last one I was getting to is the ctDNA tumor fraction high is 2.2%. It's high, but I don't really know what that means.
Right. What about mutations?
There are some, but the way they report this is an attachment, which I'm having trouble. But
all right. If you send me the report, I'll look at it tomorrow, Mark. What we're interested in, the fact that your tumor burden is low and that you're not MSI high is helpful, but it means you're not a candidate for immuno-oncology drugs. But you've got a high ctDNA is not surprising because there's a fair amount of cancer that you're dealing with right now. But what we want to know is, are there any actionable mutations that the report picked up? Is this report from FMI, from Foundation Medicine?
Yes, it is. And basically, they did not indicate that we need to do anything.
It's not that we need to do anything. It's whether there was anything that's actionable.
Well, I'm still trying to understand the report, so I'll try to get to it soon.
Okay, you can send it to me. I'm happy to look at it.
Okay, great. And although I'm tired and shortness of breath all the time, I'm actually on a roll. I'm getting a whole bunch done in my office. I'm throwing out files. I'm recycling everything, and I amaze myself that I go all day long.
Fantastic.
And so I think I'm feeling pretty well.
I think the one thing that I really learned going through this with you over the last month or so is that we get a little bit more leeway in terms of the FDG and PSMA comparison time. I was always concerned they had to be very close together. Dr. Agarwal feels they can be relatively close together. Within a couple of months seem to be fine by him. 2 or 3 months seem to be fine by him. So if it's good enough for him, that'll help us going forward when we advise other men. The other good news is, at least based on the old one, that you're concordant. And that was a huge concern of mine, that we see stuff on the FDG that we don't see on the PSMA. And that would be a heads up to be looking for this weird, horrible morph disease, and we don't have to look at it. Now, I will just mention one thing that's really important that we came across today, literally today, and the moderators have been talking about it offline, which is that there is a new test being developed, and the acronym is NEMO, NEMO, neuroendocrine mutation. I forget what the O stands for. And essentially it's being developed amongst other places at Dana-Farber by Misha Beltran. I'm going to highlight it in the next reminder with a copy of the article. But essentially what this test is for people like Mark Valens, where we can do a blood test and find out if there's any indication of small cell neuroendocrine-like disease in the ctDNA. So they'll collect this ctDNA, they'll analyze it, they can tell through the process of methylation, and please don't ask me to explain methylation, but they can tell through the process of methylation whether you are displaying early signs of neuroendocrine disease. And the moderators have all received the links to this. It looks really interesting. And Alexa, Alexa Jet, who also serves as a CDMRP reviewer for rare diseases, tells us that off the record, she's heard about this before. That's all I can say. I have to be careful, especially since I have CDMRP guys on this call.
Well, thanks. That's all for me.
Thank you, Mark.
Thanks, Mark. Mark, did you ever have any PSMA radionuclide therapy like lutetium?
Yeah, Pylarify, I think. Oh, no, I wasn't.
Pylarify is just imaging.
With different things, but I just had one recently.
No.
Which.
The answer is no. Mark hasn't had any radionuclide therapy yet.
Okay.
Therapy, no, just the scans.
Right. Okay. Well, if you have concordance with your FDG and PSMA scans, you're a good candidate for that type of therapy if necessary.
Okay.
I think there's a Mark report overall from Mark.
Yeah.
Happy to hear this.
Glad to hear it, Mark.
Yeah.
Dr. Jack, you are up.
Thank you. I wanted to have a little discussion about my Foundation 1 monitor test I got back since I'm being followed with this test every a month or two. But what I got was, fortunately, ctDNA was not detected, and ctDNA tumor fraction was not detected. All reassuring, but the mutations, and I'm new to mutations, the only thing I've known in the past that I've had really is SPOP and one other one, but what showed up in my blood was CHEK2, DNM, T3A, RAD21, and TET2. And 3 out of 4 of those are CHIP mutations, which I've had a history of when I had my original foundation some years back when I was in search of what was going on and where this PSA was arising from. So I have a tendency to have some CHIP stuff going on. That means clonal hematopoiesis of indeterminate potential, which means that I'm more predisposed to get a hematologic cancer or a cardiovascular or pulmonary disease than cancer. But that's something I have to be on the lookout for because I have a greater predisposition to that because of those particular genomic biomarkers. I just wanted to open it up a discussion because this is a new language for me. My medical training had none of this, and I have not kept up on the literature. It's a new language for me, and I know you guys have been using the terminology, genetic findings and variants. But if you can just give me some feedback about if this has any meaning that can add to my frame of reference.
What? Just give us the variants again that came up, please.
The ones of significance, non-actionable. CHEK2, D, N, Nelly, M, mother, T, 3A. Then they have little subdivisions between those two, and one is at a VAF of 11.6.
Yeah, let's stick to the bullet, stick to the headlines, Jack.
RAD21 and TET, TET2.
Okay. CHEK2 is the only one that's familiar to me. And I think, and Len will correct me, I think CHEK2 is in the HRR family as well.
Yeah.
But it's not it's not actionable by PARPs to the best of our knowledge. So even though you have it, even though it might be an HRR mutation, the other three mutations are, I'm not really familiar with any of them, so I can't say. It doesn't identify any of those as actionable, correct?
Right, non-actionable. I did a search on
So
official.
I would say that if they're non-actionable, then we don't have much. This group doesn't have a lot that we can really contribute to you because we don't know beyond prostate cancer what they're. You probably know more about their relevance outside of prostate cancer.
Right, and I just I looked it all up, and it's all academic. And if
Jack, did they give you a percentage of your chip clone?
it's called VAF, variant allele frequency, and the check2 was very low, 0.18.
No, I mean a percentage of your chip clone.
Yeah, well, the chip, as I said, 3 out of 4 are chip. TET2 is a chip. It's also the DMN, T3A, and the check2 are all part of the chip family.
So 75%
No,
of your blood cells are chip?
I never said that.
Oh, you said 3/4, didn't you?
No, I did not.
Oh, sorry.
No. I was giving you the VAF, but that's the only one that was relatively high was the one of the DNMT3As. One of the variants of that was 11.7. The rest was small. The TET2 was 3.2%, but all the others were under 0.1. So maybe whatever you know about it, John. Just throw it out to me because I don't know much other than what I read on artificial CBT chat.
Well, okay. All I can say, Jack, is you may know more about this than I do. I always thought CHIP was not anything to be concerned about. It was just kind of a false positive.
No.
I can't remember if it was from BRCA mutations or whatever, but I don't recall it.
It's what I said. It's a predisposition to hematologic cancer and cardiovascular disease.
Okay.
It gets more common as you get older, and I don't know what the normal percentage would be for someone 85, but
yeah, well,
I don't think this is a clinical issue.
Yeah.
Yeah.
No.
I what I would take out of all of this, Jack,
to
be honest, no ctDNA is fantastic.
Yes.
Just be happy, keep smiling, keep doing what you're doing, and don't analyze so much out of it that it makes you more anxious about something else.
I'm not. I just wanted to throw it out. One more thing briefly I want to bring up is that, I've got this condition with my hands where I can't close it. And I went back into I did a search on this in prostate cancer, ADT treatment, very, very large literature on so many people report that. So it may not show up in this group, maybe some trigger fingers but the osteoarthritic, inflammatory, puffy fingers like sausage is a side effect of ADT. And I have about 6 or 7 patients who reported it as I did a search. So nobody has it in this group.
I've had that, Jack. I've had multiple steroid injections in my fingers because of her finger. Yeah.
Same here.
I have it, Jack. Well, I think a lot of us are dealing with it.
All right.
On the ADT. It is what it is.
It is what
number of times that I pick up a coffee mug and I can't let it go, and I have to use the other hand to open my fingers with it.
Does anyone who's had it gone off the ADT and it went away?
Oh,
me, I've been off ADT for over 2 years, no resolution.
I was able to get rid of it through 3 years of exercise rather than the surgery they wanted to suggest. I worked on my forearms and my shoulders and my hand grip strength by doing farmer's walks with weights, and slowly resolved.
Well, that's good to hear. It's very painful to do that, though. It's hard if you can't grip to work on your forearms. You know,
I know that we call farmer's walk where you weight and hold the weight in your hand uh, and walk with it or move your arm, and over time I could close my hand around the weight and then I could lift the weight.
okay.
Just,
Thank you, Larry. Keep working
well,
on it. Thank you. Thank you.
I was just lucky. I don't know.
Yeah. Okay.
Hey, Jack, we're going to move on to Joel Blanchett. Go ahead, Joel. You muted, Joel.
Thank you, Len. Let me start back to October of last year. 28 October, I went on a two, I had just finished Orgovyx and darolutamide. I'd been on those two drugs that Dr. E had put me on for 2 years. And then she gave me a Tempest report, a Tempest XF a report and a test, and a report came back. A test for 523 genes with a liquid biopsy. And so anyway, I don't know if you guys can see this, but I guess you can't see this because I can't even see it myself. But anyway, the first gene it caught was the gene that was also in my germline, the MUTYH, was a colon cancer gene. Dr. E says that that MUTYH gene is driving my prostate cancer. I checked on the internet. Is it possible for that gene to drive prostate cancer? And the answer is a big fat yes. It also drives other cancers like pancreatic and lung and other cancers. Also, I had 1, 2, 3, 4 TP53s on the Tempest test with very low percentages. The way I understood the test, the way I read it, is that if you have a low percentage, and by low I mean like 0.8, 0.2, 0.3, that means you don't. The TP53 gene supposedly helps regenerate cells. If that's missing, the cancer can be more aggressive. And so jumping a little ahead, I've had a couple of 2 blood tests since those dates. And just on the of interest, my testosterone was less than 10 when I came off the 2 drugs. And she put me, after she got my Tempest test, she did put me back on darolutamide for forever, as far as I can see. But she left the Orgovyx out. And my testosterone used to be less than 10. Now in November it was 14, and in January it was 32. So it's going up, but very slowly. She didn't think I would ever recover my testosterone, and it looks like she's right. It's not going up very fast. So she's giving me a blood test, ordered a blood test for the month of March when I go see her. And she has ordered 2 new tests that I've never taken before. One's called a CEA test. The other one is a chromogranin test, which we've talked about in this room before. That's basically a neuroendocrine test, the chromogranin. The other test basically tells you if you've had cancer, or if you had cancer treatments, if you still have it. So she's checking my blood to see if my cancer is coming back or if the treatment was successful. And that's the CEA test, and I can't even pronounce it. It's like carcinoma embryonic antigen test. CEA. CEA is the short. Maybe the docs can tell me what that means. But anyway.
Chorionic embryon antigen.
Oh, Jack, it's carcinoembryonic antigen, CEA. It's It's non-specific for many cancers.
Yes.
Carcinoma embryonic.
But this is the first time. Of course, she's given me the alkaline phosphatase test that Dr. Vogelzang was preaching on for many years. Also, the LDH test she gives me regularly. But those are two new tests she's never given me before. So she is watching out for me, making sure my cancer doesn't morph into neuroendocrine. So that's my report.
What was the name of that germline mutation you said you had?
It was MUTYH. It's a colon cancer gene.
Okay, right.
They tell you, a genetic counselor said, "Oh, you don't worry about it. Only if you have two of them, two alleles, will they could affect your kids if they develop two. But if you only have one, not a problem." Well, Dr. E is saying, "Oh yeah, it's a problem. It can drive your prostate cancer and other cancers." So I was impressed when I got on the internet and researched it that it certainly can drive cancer, prostate cancer. So anyway, it'd be good to get some more clarity from Dr. E on that.
Okay, thank you, Joel. Any questions for Joel or comment? Oh, we have a hand up. Let's see. Dr. Jeff, go ahead.
So, Joel, I'm not aware that CEA is a test to look for prostate cancer. It's ovarian cancers and bowel cancers. So, is she doing that for your prostate cancer, or does she do it to look for other cancers not related to your prostate?
Well, she never told me why she's doing it, but as far as I know, let me see. Yeah, according to the internet here, CEA levels can help confirm the presence of cancer, especially after diagnosis or treatment response to cancer, to determine how well cancer treatment is working, or CEA levels can help determine if cancer has returned after treatment. I don't know what she's checking for, whether she's checking for other cancers or how well the darolutamide and the Orgovyx has worked for the last 2 years.
So
I would ask her because I'm totally unaware of CEA used to monitor prostate.
Dr. Jeff, the way her mind works, and she's so smart and she's so good. She's concerned about this MUTYH, which is germline. MUTYH can be associated with a whole bunch of cancers, and it can drive the prostate cancer. What she's doing, I suspect, is keeping an eye on the prostate cancer and making sure that no other cancer is arising as a result of this MUTYH. And I don't think there's a percentage for us in pursuing this more. She's also concerned about morphing, which is why she's going with the chromogranin. And I do suspect that if she had that NEMO test available to her, she'd probably be using that NEMO test.
I asked her about the NEMO test, and she says, well, it's not proven yet that this is an accurate test. Because I had viewed a short presentation on her part along with a couple other doctors, and one of the urologists had suggested the NEMO test, and she was not in favor of that test. So that's
well, it confirms this sort of what I said before. It's still early in the day. It's still in the lab. It's not commercially available.
Right.
Anyone else, or else I'm watching Len's time.
Yeah. Well, we did have 3 fellows who said, I don't really need to go tonight, Rick. So we're not in such dire straits.
Oh.
I've got 2 more on my list. And maybe if those other guys want to jump back in, they can. But
yeah,
I've got Joe Commanda, then Steve L.
Okay.
Is Joe with us?
I'm here.
Okay, go ahead, Joe.
All right. I'm taking Orgovyx, and that's all. And I've talked about it here before. I just started in October. I think it's going pretty well. My doctor wasn't interested in dual therapy or whatever they call it. duplet, whatever, doublet, what they call it, doublet, because she said that if I had been tested today with the technology when I first became metastatic, they wouldn't have found anything. I don't know, there was some kind of argument like that. I'm probably scrambling it a lot. But that with today's technology, it would maybe justify uh, having the doublet therapy, but not with yesterday's technology. It had something to do with the tests they had done in the trials or something like that. Does that make any sense?
Yes.
It doesn't. Oh, it does. Okay.
We're familiar with that.
Okay.
So what, Joe? What is your question for us, or what's?
Oh, I just want to know if it made sense to you.
Yeah.
Okay.
What they're saying to you is that if at the time that your cancer started to rise, we would have used some of the scanning techniques we have today, we would have seen the metastasis, and we would have given you 2 drugs, doublet, right off the bat, because we would have said, oh, he's metastatic and his cancer's come back, and that suggests you should use 2 drugs. But at the time, we didn't see it because we didn't have that technology, and you didn't really want to go on hormone therapy. Now you've decided you do want to go on hormone therapy, so she's just going to give you 1 drug because that's what they would have given you at the time. Now, does that make sense to me? Not at all.
That makes sense.
Sort of is she justifying? Is she just using a justification? Yeah, to me, she's just using a justification. It's a bunch of BS. I think that if we know you have mutations, if we know you have metastasis, and we know you need hormone therapy, should we be giving you doublet? Yes, we should be giving you doublet. But she doesn't want to give you a doublet, so that's where we are. That's how I interpret. Len, do you see it like that?
I do. Yes.
I agree.
Okay. Thank you.
So the bottom line is that if you want to really push her, and you feel like you would want to go on doublet, you probably have a very good case to make. If you want to go with her judgment and just go on the Orgovix, stay on the Orgovix and add it when you need it. But what we seem to think is that for a man like you, with the way your disease progressed and the pattern, given all of the technology that we have, your best outcome would have prescribed a doublet therapy from the outset.
Larry, go ahead.
Is she concerned about the side effects of the anything she might add to the Orgovix? I found Orgovix to be pretty darn effective, and a doublet therapy brings with it some additional side effects. Are you candidate for any of those side effects?
I haven't had too much, really. So I'm not
Was you
eager to have.
testosterone, Joe? When you went to before going on the Orgovix, did you test your? Hopefully, you tested your testosterone. Did you?
Yeah.
What was it?
Yeah. I'd have to look it up, but I think it was around 300.
Okay.
And it's down to 3 now.
Right.
Okay. Steve Lodge, you're up.
Yes, thank you.
3 nanograms per deciliter on Orgovix alone?
I'm sorry, could you repeat that?
3 nanograms per deciliter on Orgovix alone?
Yeah, that's what he said. Yeah, that
Seems
makes sense.
good.
It's not unusual. Is that all you had, Steve?
No, I was just starting, then stopped.
Hold on, Steve. That wasn't Steve that said that. That was, I think, Larry.
Oh, sorry.
Mason, you don't need any additional suppressor.
Okay. Go ahead, Mr. Lodge. Jump in quick. Take the mic before anyone else grabs it, man.
Yes, my original PSMA gallium test in February of 22 indicated no visceral organ metastasis. Just completed a pylarify test, and now it reads mildly increased radioactive tracer tracking along the left seminal vesicle, concerning for local recurrence. Correlation with MRI is recommended. Otherwise, attention on follow-up. And I'm just trying to understand how concerned I should be about that.
Well, I'd say not very concerned, but go ahead and get the MRI. That's good advice.
All right.
I can't recall your history, Steve. Just quickly, what's your Gleason and
Gleason 9, de novo metastatic, hormone sensitive. Went to
what?
castration resistant in January.
Okay. You had metastasis to the bone at some point?
Yes.
But now you only have it to the seminal vesicle?
That's all they're seeing.
Mm-hmm.
And actually, and they were at a couple of nodes, but one of those is no longer showing anything, and the other one is showing substantially milder reactivity.
And what's your PSA?
0.79, 0.79. Was undetectable for about 2 years and started working its way up in January.
So they're recommending an MRI for confirmation of suspicious lesion in the seminal vesicle. And what else? Are they recommending any therapy at this point, or they want to wait?
Oh, I am looking at some radiation therapy starting for both the primary and some of these locations, whatever they'll do.
So they have not debulked the primary yet, is that correct?
That is correct.
Yeah. And you're still on Lupron and Abbey.
Correct.
I think it'd be a great time to debulk the primary and take care of this.
Yes, and I have a referral to the radiation oncologist. They've already called me back once and with some questions, and I'm just waiting to get it scheduled.
It's interesting. It raises an interesting discussion for you to have with Jastrzębski and the radical oncologist, both of them. When they debulk the primary, typically they don't do more radiation to the nodes across the pelvic girdle. Just debulk the primary in men. This is in men who are metastatic. I've never fully understood that. It seems like there's good reason because we're not seeing anything bad around from anywhere else except the prostate itself. But I would probably be asking them, pushing them, and asking them should the radiation we're going to do, since we already see something outside of the seminal vesicles, does it need to be wider than just in the prostate? That would be my question. That's what it raises in my mind. Len? or Dr. John?
I agree.
That's what I am pursuing. Uh, and actually, there seems from Yevzefsky there was more. He was willing to shoot the bone locations, and I actually brought up the primary, and eventually I think he thought that was okay.
Did your pulmonary embolism completely resolve?
No, I had a CT scan at the same time as the Polarify, and it showed they phrased it as it had mostly cleared, but it still persisted.
Thank you.
Are you still on Eliquis, Steve?
Yes.
Yes?
Yes, I am.
Well, the good news is if you're on it, if you're on it next year, it's going to be one of the drugs that they're negotiating the price on. So maybe you'll get cheaper. And by the way, guys, and if you picked it up in the reminders, so is enzalutamide.
Yeah, I'm going to hit the $2,000 limit this year and be fine. All right, thank you very much.
Okay, Steve. Well, let's see. Dr. Jeff, I know you previously declined. Do you want to jump back in the game?
Yeah, maybe 2 minutes. So I just want to relate a story. It happened to a very dear friend of mine who's been battling our disease for 12 years. He's 68 years old, and he had a Gleason 9, 4 plus 5. He was on Lupron alone. He had metastatic disease to 2 ribs, and we had a conversation. I told him to go back, get on a second drug. They agreed, and they put him on Xtandi. He'd been on Xtandi and Lupron for 3 months, and they did a PSMA scan. His PSA had gone down from 0.45 to 0.36, but they did a PSMA scan, and of course it saw the Mets in his ribs and some lymph nodes, but they told him you have liver Mets, and they were going to go through they were going to put him on triplet therapy. They were going to send him for radiation to his liver. And I said to him, why don't you get confirmation? I read your report. It said, it didn't say definitive liver Mets. So he got an MRI. He demanded an MRI, and the MRI showed he has 2 cysts in his liver, and there's no malignancy in the liver. And I tell that story as a caution because they were going to set a whole cascade of stuff in motion for something he actually didn't have.
Mm. Who's treating him? Where's he getting his treatment?
It's in Orlando. So I don't know where, but it's in Orlando, Florida.
Okay. You know, what's also interesting is, believe it or not, is that early liver Mets are actually correlated with better outcomes. Late liver Mets, no, but if we see people with liver Mets early in the disease, it's actually been correlated with, assuming they're treated and they go away, it's been correlated with relatively good outcomes. You should you should tell him that as well.
Although he doesn't have them, but yeah,
he doesn't have he doesn't have them, so he can.
It's even better.
Let him feel better for the people who do have early liver Mets.
Well, thanks for sharing, Dr. Jeff. That's a good point to keep in mind. If we get some dire prognosis, double check that.
Well, I mean, look, there's a couple of things on there that I want to say. First is, we know that a huge percentage of guys who should be on doublet are not getting doublet. We've seen that very recently in the Dan George report that you guys commented on and got published and all the rest of it. And it's a huge percentage. These men are not getting treated right. The other thing is, it also points to the fact that you've got to get treated by people who know what they're doing when it comes to prostate cancer. If you would have gone in to Dr. E with that, she wouldn't have been that concerned. She would have been checking it anyway, but she also would have known that early liver mets may not be so serious. So try and move this guy to a center of excellence for follow-up.
I have been.
All right, Dr. Jack, your hand is raised.
About a year and a half ago, I don't know, at some point I had something on my liver and I was very concerned. And Dr. Belusic, he was smart enough to order an MRI to make sure, distinguish whether it was something benign or malignant. And there are certain criteria that differentiates cyst that can be and looks malignant versus a benign one. And I remember reading all about that in terms of how it looks, how dark it is, how it's shaded, how much liquid and everything else. And fortunately, it turned out to be a benign cyst. But, you got to follow those things also because they can shift, and they can convert. But I went through it, was frightening, and I can understand how your friend could have been frightened.
Yeah.
Yeah.
Was there anyone else who, either Tony Fig or Jim Marshall, who...
Thomas has his hand up, Len.
Oh, sorry.
Yeah, okay. Yeah,
Yeah,
thanks,
Thomas.
Glenn. I was just wondering, Dr. Jeff, what was your friend dealing with any specific insurance company? Did he have Medicare or did he have Medicare Advantage?
He has Medicare. I think he has Medicare Advantage.
Thought we were getting some. I thought there were some things in the notes about patients not getting more advanced treatments, and at least some of that was coming from the Medicare Advantage treatment groups.
Yep, you're right, Thomas. Yep, there was a study came out last week, and I think it was JAMA, showing that men in, but this was not prostate cancer. It was looking at colorectal and lung, I think. In the patient group that they were looking at, the men, the people in the Advantage plans were 10% less likely to get more advanced cancer drugs.
Okay, yeah, and I mean, to me, that should be a little subnote attached to this kind of information because it does, at least 10%. It does make a difference.
Okay, so Tony Fig, is there something quick?
I was has to do with radiation side effects. I had 38 treatments of pelvic bed radiation and began in March of 23, and getting a lot of pain in my right hip, and so I had to have a hip replacement. And now I'm a year out further, and I'm having problems with my left hip, and the spacing in between the joints has really decreased significantly between last year and this year. And I asked the doctor if radiation would have any effect and cause that, and he said no. But it just seemed rather strange to me. And also, I'm going to have a cyst this week for a possible stricture because of slower urine flow. My question is, has anybody heard of it, radiation affecting the joints?
I'm not sure it's the radiation. It's
Anybody?
but the radiation may have an aspect, but certainly the ADT does.
Oh.
You know, we talked. Dr. Jack mentioned that earlier on today. We know the ADT can cause bone thinning. You know, I went through 3 years, 2.5 years of, and after that, I finished up with 2 hip replacements. Now, do I think it was the radiation and the ADT, or do I think that I had proclivity to osteoporosis and calcium issues? I put it down to the latter, but I also think that the ADT didn't help and the radiation didn't help.
Okay.
All right, and Larry Schuler, and then Don Rogers. You have your hands up. Go ahead.
It could be tricky to determine a cause for the hip problems. But, have you had a bone mineral density scan?
No, I haven't.
Yeah, if you had 2 of them where you could compare what you were before radiation and what you were after, is it the bone that had the problem, or is it the soft tissue in the joints?
It's the just the cartilage and everything has worn away.
Yeah. I've heard of radiation causing problems with the cartilage. I'm not well studied on that. Also, I have read that radiation can cause urethral strictures.
Mm-hmm. Yep.
But again, finding
you'll probably never know for sure.
Or no, we'll never know.
Right.
Okay, Don Rogers, go ahead.
Yeah, I had 34 sessions of external beam, and it caused necrosis on my left femur head, and I've been told that both by the radiation oncologist and by the doctor who actually read the MRI of my hip.
This is done. I'm gonna write next week's invitation. I think about fractionation of X-ray therapy and outcomes. Maybe I'll be able to touch on this a little bit.
Please do.
Whilst we've got Don Rogers, would you like to give us a quick report on your luncheon, which missed Dr. Jack? Where was Dr. Jack for that luncheon?
I couldn't drive that far again. To drive an hour and a half for me is just not.
Okay, well, you were missed. How was the luncheon?
The luncheon was great. Dave Muslin, he was very persistent, getting it organized. And what's amazing about it, we went to this place called the Tin Muffin. I've lived here in Boca Raton for 44 years now. I've never been there. My wife goes there all the time. Great place. Enjoyed it a whole lot.
Great. I enjoyed seeing everybody's picture, and I'm so pleased that you guys got together. And we went there. When I was there the year before last, this time of year, and they had a little lunch and they had a get together. That's where we went, the Tin Muffin. It was good.
Well, Jim Marshall, you're the only one who I haven't really gotten to. You, even though you declined, would you like to jump in?
Not with the update. I can hold that with a question. And with ADT versus the heart. Okay, I had a triple bypass March, and I probably will be returning on to ADT, essentially abiraterone or some drug. Implications of doing that. I've read the things that say, well, heart issues. Okay, I've got AFib. Let's see, a heart murmur, and peripheral neuropathy, which I don't think plays to this. So, what are the bad points affecting the heart?
Before we go there,
Okay.
what makes you think you're returning so soon? Has your PSA been rising?
Well, actually, that was a part of the update I was going to do, which was started in March up to 0.03, and today, end of December, it's only 0.07.
So what I would say is we can defer this conversation until we're in a position where you really need to think about going back. At 0.07, it's not there. And
Right.
we're happy to have the conversation. There is a oncocardiology presentation coming up with power in the cancer patient lab that I've been featuring in the reminder for the last couple of weeks. I can't remember it. I think it's next week. This week is on the gut, on the effects on the gut. But the following week, we've got a couple of people who follow this closely, like Dr. John. I would say this: we don't need to have this discussion at this point in time until we get quite a bit closer. If you were at 0.1 right now, I'd say fine, let's jump into it. But at 0.007, the difference between 0.003 and 0.007 is totally a testing error. So, Dr. Jeff?
John, Jim, I do think that abiraterone can cause peripheral neuropathies.
Well,
I wouldn't miss it.
Actually, I got it from the triple bypass. Okay, out of that. Somehow, I don't know how.
Yeah, but it is common for hormonal therapies to cause peripheral neuropathy. Rick has it. I've got it in my toes. I never had chemo, neither did Rick. Just something we deal with. It's not a big deal. Go ahead, Rick.
No, I meant to put a thumbs up. Sorry.
Okay.
Okay.
You did it, Len. You did it. And you're only 10 minutes over and you got through 2 guys and 10
Newbies.
people.
At least 10 people, yeah. Okay, additional people. So thanks for the great discussions, guys. We'll see you next Tuesday when I think Dr. John is moderating. Okay. Good night.
Good night, everybody.
Good night. Thanks.
Good night.
Thank you, Rick, especially.